Thank you, Dr. Tamer. Right. So this is the last time. I don't think I'll be here again today anyway. In terms of, I used to know a person who, whenever they give a talk in the afternoon, before the end of the session, would ask everyone to stand up, stretch their arms, and then sit down. I think the theory being that people would feel refreshed and more awake. You'll be glad to know I'm not going to ask you to do that. But what you might not want to know about is I'll be asking lots of questions to make it a bit more interactive rather than just one-sided. So, can anyone tell me what normal height is? What is the normal height of an individual? One 160. So all the people below 160 are abnormal and all the people above 160 are abnormal. No? Yes? Okay, what's normal weight? 60 kilos, 70 kilos, 80 kilos? All weight is good. Okay. Fantastic. I mean, the reason for asking this question is that defining normal isn't easy. We seem to think in endocrinology that we know what normal is. And one of the reasons I think I hope that by the end of this talk, I'll try and convince you that rather than saying normal and abnormal, we should be thinking more in terms of reference ranges, because it's a reference against which we are comparing the actual result that we have to, rather than classing it as normal and abnormal, which automatically creates the impression that abnormal has to be acted on. Okay? Right, let's move on. So the Collins Dictionary defines normal as something that is usual, regular, common, typical, or something that it constitutes a standard. So somebody said 160 centimeters, I assume it can't be feet, can it? No. 160 centimeters is normal. Well, a lot of people probably would disagree with that, and including myself. So what I'm trying to say is that there's usually a range, and it's really important to know where that range comes from. How many, please raise your hands, have actually talked to your biochemist in the hospitals or the clinics that you work and asked them where their reference range for TSH comes from? One. I know a lot of you are shy, but how many of you have actually talked to a biochemist? Not about reference range, about anything. One of the important things I think as endocrinologists we need to do is actually have that conversation with biochemistry. Just like neurologists work with neurosurgeons, we as endocrinologists need to work with biochemists in understanding the results, because we are acting with patients' health based on the information that is coming back of these results. So unless we have that conversation, can I just ask you, what was the response you got from the biochemist about where they got the reference range from? Okay, thank you. So they're adjusting the data for the population in the hospital. Now, there are obvious issues with that, which we won't get into, but clearly it's really important to understand where normal comes from. And we all call it normal, but it isn't really normal, because what we are automatically doing is, if we say a TSH of 0.4 to 4.5 is normal, then 4.51 is abnormal, whereas 4.49 is normal. Okay. Again, normal for one person might mean something completely different for somebody else. So we just have to be mindful. I suppose the fundamental question is, why do we use TSH as our first line diagnostic test when we are assessing someone's thyroid function? That's predominantly because TSH is a very sensitive marker of circulating T4. And what do I mean by that? So for example, on the x-axis, you have the free T4, and on the y-axis, you have TSH on a log scale. So as you see on the log, it goes up by 10 times from each unit. So 0.01, the next one would be 0.1, the one after that would be 1, the one after that would be 10, 100, and so on. So that's a log scale for each unit. So what you see is that for each change in free T4, there's a big change in TSH. And mathematically, it's thought that that relationship between T4 and TSH is such that for a twofold change in T4, meaning either a doubling or a halving of T4, TSH levels change 100 times in the opposite direction. Okay? So let's try and work it out. We have somebody whose, say, free T4 is 20, and that is within the reference range. And the TSH is 1.5, which also is in the reference range. So clearly, this person is normal. And I say normal in inverted commas because that is what the reference range tells us. Now, imagine this person's T4 came from 20 down to 10. And the reference range for free T4 goes from 10 to 22 in the institution where I work. So 10 is also normal. 20 was normal. 10 is normal. So if you just did T4 as a first line test, the first test would be normal. The second test would also be normal, right? But what would you expect to see with the TSH? When it was 20, the TSH was 1.5. What would you see? Stay the same, go to the left, go to the right. Go up, all agreed? Any guesses what it might go up to? The mathematicians amongst you? Yeah, and you'll see I've got 150 there, so I wouldn't have just put all that effort in if I'm not going to use that number. So yeah, so you'd expect the TSH to actually go up to about 150. The T4, remember, is still normal, but the TSH isn't. And that's the reason why we use TSH as a first-line diagnostic test. So therefore, having that information is useful. So TSH is our first-line test. Now, what's important to remember is that this relationship might work for the majority of patients between TSH and T4, but there are lots and lots of caveats. And what are these conditions? Before we go into that, how do we in reality define what is normal? The normal comes from a statistical model. A statistical model is if you collect information about 100 people, the middle 95 are normal, the top 2.5 are high, and the bottom 2.5 are low. And it's a statistical model. It's not designed on outcomes. It's not designed on any clinical data. It's based on the fact that there's a higher risk of people in both of these small subgroups developing problems. So, therefore, as you'll see, the 2.5th centile of TSH lies around the 0.3, 0.4 mark, and the 97.5th percentile lies, depending on which population you look at, about the 4 to 4.3 mark for the bulk of the population. Now the problem, and the biggest data for this historically was the NHANES study published in JCNM by Hollowell in 2000. As Dr. Bashir was telling us, a lot of that comes from the population that we see. The problem, for example, is if you only look at hospital patients, is that it's a select group of patients that come to hospital. If you just look at the population, it'll reflect the distribution of the population. The majority of participants in the NHANES study, 80%, were between the ages of 20 to 50, because that's the bulk of the US population. The data is designed to reflect the spread of the US population. Does that mean that reference range would apply to an 80-year-old, a 90-year-old? It's an important and relevant question, and the answer is no, it doesn't. Because if we just looked at age groups, then the reference range would be very different. But the issue is we don't have age or sex or any other adjusted reference ranges. We just have a one-size-fits-all for all adults. So, and the problem is, as clinicians, we've actually stopped looking or speaking to our patients. We look at results. The patient comes into the room, and we're busy looking at the computer screen because we're looking at the result. The patient's there, the computer's here, and the patient's saying, I feel this, I have that, and you're saying, yeah, you're fine, but your TSH is fine, you'll be okay. Yeah, but I have this problem. Yeah, that's fine, but your TSH is normal. So I think it is important to also try and get the clinical situation and the biochemistry together to be able to make more sense. The reference range kind of changes depending on the situation. So on the left-hand side to you are the situations where the TSH might go up, and on the right-hand side are the situations where the TSH might be lower. And we've talked about age. Obesity is another big one. It's interesting that the whole issue of obesity impacting on TSH, and I'll come to that again in a minute, is the pathophysiology is related to the excess adipose tissue releasing leptin. Leptin then works on the hypothalamic pituitary axis, releasing TRH. TRH obviously leads to more TSH production. TSH levels are higher, but leptin also converts more T4 to T3. So therefore, in obesity, you not only find a higher TSH, but also a slightly higher free T3, if you like. So how can somebody with, say, a BMI of 50 with a TSH of 4.6 be hypothyroid when the free T3 is actually at the upper end of normal? It's merely reflecting the altered pathophysiology in that person. And what we do is by saying your TSH is abnormal, we are kind of attributing the weight gain to hypothyroidism. And then the expectation is when we give them thyroxine, 50 microgram, 100 microgram, or 150 micrograms, they will be losing all those excess 70 or 80 kilos. And most would be really, really disappointed when they come back 6 months later, either having not lost any weight or maybe 1 or 2 kilograms at best. So I think it's kind of important to have that situation in mind as well. We have been debating, when I say we, as a collective community, about what is the reference range and whether it should be narrower or it should be wider. And this has been going on for, since 2005, coming up to 18 years now. So this was a debate that was, published in JCNM in 2005. Now, I again say normality. So as we see here, the upper limit of TSH on the x-axis, and what we have is the prevalence of hypothyroidism as defined by levothyroxine prescriptions. So this is fairly recent. This is just about published in the European Journal of Endocrinology. What we looked at is the various labs in the UK, 180 or so of them that supply, or provide a service to the hospitals, various hospitals in the UK. And we looked at the prevalence of hypothyroidism as defined by levothyroxine prescribed patients in each locality. And each lab has its own reference range. So the labs that have an upper limit of normal that's higher has a lower prevalence of hypothyroidism. So say a lab where the TSH level goes up to 6 as being normal, the prevalence of treated hypothyroidism in that area is lower. Some areas have a laboratory reference range of 3.5, and there the prevalence of hypothyroidism is much higher, and that's adjusted for age and prevalence of obesity and all sorts of other smoking and other variables, suggesting that reference ranges are actually having an effect on our prescribing habits, and that isn't surprising. Similarly, free T4 reference ranges, as you'll see at the bottom of your screen, has the same effect. Around the 9-10 mark is when it starts, the prevalence goes up. So that's the lower limit of the free T4 reference range. So that, I think, just kind of suggests what we think might be happening with prescribing habits. This is an interesting study from Canada, where in Alberta, I think if I remember correctly, around 2014, the various hospitals there decided they would have one combined reference range for TSH rather than various hospitals having different reference ranges. And for a lot of hospitals, that meant reducing the TSH range from about 4.5 of, I think, somewhere up to 6 down to 4. So they decided 4 is the new upper limit of normal. And as you can see from here, the number of prescriptions for thyroxine, new as well as renewed prescriptions, just went up subsequently. Again, it's not a randomized controlled trial, but it's really interesting observational data. There's no other explanation for why thyroxine prescribing would go up immediately afterwards. Again, we come back to this. So in the enhanced study, as you'll see on the left-hand side, we see that the shift to the right of TSH with age is real. And according to their data, the 2.5 to 97.5 percentile was up to about 7.5 for people above the age of 75 in the enhanced study. So again, suggesting that having a TSH of 6.7 or 7 in an 80-year-old is probably quite within the reference range for that age group. And again, this is data that we published last year from the northeast of England, from laboratory results, and we saw that the median TSH actually stayed fairly constant about the 2.1 mark, and then around the age of 60, it starts to go up in people without existing thyroid disease. And then it went up to about 2.5 or 2.6 at the age of 100 in these patients. And what's interesting is if you used age-appropriate reference ranges in how you define subclinical hypothyroidism. So on the left-hand side of the screen are using our usual reference range, which isn't age-adjusted. But on the right-hand side of that bar is if you used an age-appropriate reference range. And you find that across the various age groups, the prevalence of subclinical hypothyroidism was remarkably constant at about 2.5%, and not 5 or it went up to about 9% in older people. So if you used age-appropriate reference range, it makes a big difference to the number of people we will diagnose with subclinical hypo, but not as much to subclinical hyperthyroidism, because the lower limit doesn't really change that markedly. And a similar study from elsewhere that suggests the same thing. If you use appropriate reference ranges, the number of people that we diagnose actually goes down substantially with subclinical hypothyroidism. Time of sampling is important. As we've seen, TSH levels are higher just after midnight. 2, 3 in the morning is when it's highest, reaches lowest time about 2 or 3 in the afternoon. And this is again data from various laboratories that use the same assay in the Northeast. And we find that the actual median levels of TSH are lower during working hours than if they came in. So if you have somebody coming in, say to hospital because of something unrelated and they have a thyroid function measured, what we find is that TSH at 2 in the morning would probably, a lot of those would be diagnosed with subclinical hypothyroidism. But if we repeated the same test later in the day, there wouldn't be any more. It's not because that TSH is doing anything different, it's doing what it's meant to be doing physiologically. And again, if you used time-adjusted reference ranges, we find that the prevalence of subclinical hypothyroidism is remarkably stable across all time periods, about the 2.5% mark. Whereas if you took people between midnight and 8 in the morning, the prevalence is closer to 10. Whereas, if you took the time, it's a quarter of that. Iodine has an important effect. So this is a study from China that looked at thyroid function from when they were iodine deficient to when they actually moved across to being iodine sufficient. And they found that the proportion of people being diagnosed with subclinical hypothyroidism actually went up quite significantly. Body weight, I did say I'd talk about that. Again, you'll see on the left-hand side is the various BMI categories, and you see that the effect on TSH and free T4 is in the middle. There is this gradual increase in TSH across the various BMI categories. And on the right-hand side of the screen is the number of prescriptions for levothyroxine in each area of the UK, defined by the population percentage of obesity. So areas in the UK that have a higher proportion of people that are obese have a much higher prevalence of hypothyroidism. That's probably a selection bias, but it also suggests that we are detecting a higher TSH and we are treating a higher proportion of these people with levothyroxine in the kind of hope that weight will go down. And that brings me to the question is, are we kind of over-treating, over-diagnosing a lot of these patients? Are we medicalizing what is essentially a lifestyle issue? Maybe that, but that could be a debate for a different day. What about weight loss? So bariatric studies suggest that post-weight loss after bariatric surgery, there's a significant reduction in TSH, up to 0.5, maybe even more across the spectrum. This is something that's actually in review, so I can't really talk about this a lot, but this is the effect of a GLP-1 that a lot of you would be aware of. That's exenatide, which is, I believe, less commonly used now. But in patients with type 2 diabetes, when they lost weight, what was the effect on their TSH? So they had thyroid function before they started exenatide, and they had thyroid function subsequently, 12 months later. And what you'll see here is that you have change as a percentage of the baseline weight on the x-axis, and change in TSH as a percent, not as a percent, but the actual change from baseline on the y-axis. And you'll see that in the people that don't lose any weight, which is 0 on the x-axis, the change in TSH is approximately 0. But as you lose more weight, which is the 5% or the 10% or even the 15%, there is a significant reduction in TSH But if you gain weight, and some people do gain weight occasionally with GLP-1s, actually TSH levels tended to be higher. So again, suggesting it's not the effect of the GLP-1 agonist, is the impact of weight change on TSH levels. So it's again suggesting that in people with obesity with slightly high TSH, weight loss is important rather than treating with levothyroxine. And then we have this issue of a third person in the room. In clinical consultations, it's not just you and the patient. There's always the internet. And the internet is a real issue for each one of us faces on a daily basis. And it can give you any information that you wish to look for. And one of the websites that I have here from a place in Denver called, you can read it. What they see there is that optimal TSH hormone levels are 0.5 to 5 according to the mainstream medical community. I've highlighted the words. And they say we recommend 0.5 to 2.5 though. And it's these wordings that our patients will see. So the question is, you have somebody with a TSH of 3 and they have symptoms, say with fatigue, and they have a look online, they'll come across this website and they'll say, you are the mainstream and you're saying, 3.5 is normal, but this website is saying 2.5 is normal. Try having this argument with them. And there are lots and lots of these. I don't think I've got that much time left to be able to go into detail of the many, many other websites. I'm sure you're all aware of these. One of the consequences is that levothyroxine prescriptions are increasing, and we've talked about this yesterday. For those of you who are here, it is increasing every year. So, to end, normal varies from person to person. TSH isn't a fixed molecule. It's impacted by a variety of factors, which, if you don't take into consideration, may lead to inappropriate management. I think we need to have more region-appropriate reference ranges, and also we need to take other factors into account, whether the laboratory states those or not, but I think we as clinicians should have a look at the person's age, their weight, their clinical condition, the iodine status, if you can, if you know what the iodine status of the area you're living in and working in is, I think is important. Possibly harmonizing TSH results, just like we did with HbA1c, would be an important factor to consider, so that TSH levels, wherever you are in the world, would reflect a similar value and mean the same thing to clinicians around the world, would be something to consider. And I think, finally, we should be treating people rather than numbers. Thank you very much.